Welcome to the voices of transparency and excellence. We're not pivoting, the world is spinning like a top. Let's stop, figure things out, get some answers. Come with us on this ride. Warm regards, Rick and Judi.
Welcome to our podcast series where we address crucial topics impacting our campus and community. I'm Judi Clarke, and I'm here with...
And I am Rick Gatteau, and today we are joined by Marci Lobel, Stony Brook University Distinguished Teaching Professor from the Department of Psychology and Director of Stony Brook Stress and Reproduction, or STAR Lab, and Adam Gonzalez, Founding Director of the Mind Body Clinical Research Center in the Renaissance School of Medicine here at Stony Brook University, and co-chair of the Stony Brook Medicine LGBTQ Committee. Welcome.
Thank you. So Marci, we're going to start with you first. What are the most important pieces of information that we should know about women's health, particularly here in the U.S., and what are some unique disparities?
So I think one of the most important bits of information for all of us to know is that heart disease is the number one killer of women, despite the fact that many people misunderstand and believe that breast cancer is a major health problem for women. Now, it is the most common type of cancer, but even among cancers, lung cancer is the deadliest cancer for women. And the lack of information and understanding about what women's true health risks are can lead to women ignoring symptoms that they may have, which, by the way, often present differently than for men who have heart disease. They may delay seeking treatment for those kinds of symptoms, which could include something as innocuous as fatigue or nausea or weakness. So it's very important for us to remind others what the factual or evidence-based problems are that are faced by women. Judi, your second question was about disparities.
Correct. Thank you.
So it's well documented that women's complaints, and I'm careful in when I use that word, when I use the word complaints, their reports of symptoms that they're experiencing are not taken as seriously by their healthcare providers. And so women can be dismissed when they do report the kinds of symptoms that I just mentioned. That's a very serious problem. And women's pain is also not treated as seriously as men's pain. So women are often underprescribed the treatments that will resolve pain problems. And some believe that they're overprescribed antidepressants when their healthcare providers can't find an organic reason for some of the symptoms they're experiencing. I always say that we also have to consider the possibility that men are being underprescribed antidepressants and that it's under-recognized and under-treated. And I could spend the rest of the day talking to you about maternal health, some of the disparities that exist just among pregnant and childbearing women. I'll just say in short that the United States has one of the worst records, the highest prevalence of low birth weight, preterm birth, and neonatal mortality of any industrialized country. And we have very large racial and ethnic disparities in the U.S. in those kinds of adverse birth outcomes. And if you want to know more, I'm happy to return to that topic.
Yeah, I think it's a fascinating question to address. Let me go to Adam. If you could equally, I know we just talked about women's health, can you talk about what we should know most about men's health in the U.S., and then same question about any disparities that we should be aware of?
Yeah, absolutely. Well, first I'll say Marci is absolutely right. In terms of depression and men, we know that depression is underdiagnosed in men and likely undertreated as well, which is a significant problem. When it comes to men, we know that men live on average 5 to 6 years less than women, so there are definitely some significant problems there to be tackling, especially with Black and Native American men having the shortest life expectancies. Similar to women, heart disease is also the leading cause of death for men, with higher prevalence rates in Black and also low-income men. We also know that there are certain cancers that affect men more than women, with higher rates of lung and colorectal cancer, and perhaps specific to men, also prostate cancer. And here, Black men face the highest rates of prostate cancer deaths. And overall, 1 in 8 men will be diagnosed with prostate cancer. So definitely something for men to keep in mind when it comes to screening and preventative efforts. When it comes to mental health, which is, my area of expertise as a clinical psychologist, that men are 3 to 4 times more likely to die by suicide than women. And they're also, as I mentioned before, underdiagnosed for depression. So that's something that we really need to be focusing on. There are also higher rates of alcohol and drug abuse, overdose deaths. So there's lots that we can be doing to help addressing some of those barriers, too, that are preventing men from seeking and accessing care. We know that men are less likely to have a primary care doctor. They're also less likely to show up for their doctor visits and get regular checkups. So in terms of addressing some of these health problems, there's lots that we can do.
It's interesting. So Judi and I get to work with a lot of our Stony Brook students, as you do as well. And one of our data points does show that men do not seek care at the rate that women do, particularly in the counseling realm. And look, I'm sure there's a lot to unpack there, but what contributes to that? Because that's starting at the age of a teenager where you learn those habits, and I'm wondering if that carries through in your young adulthood and into your adulthood.
Yeah, absolutely. It's a huge issue when it comes to perceived societal norms and also cultural expectations, where it's kind of grilled into us when we're really young that men are tough and men need to toughen up and we're rough and we should be able to handle things ourselves. And so I think as a society, especially here in the U.S., that is a narrative that's constantly being put out there. So having more awareness around some of these societal norms is important.
Yeah, I would agree with everything that Adam just said. But in addition, one of the explanations for women's greater use of the healthcare system is the fact that from a very young age, we begin using it for all kinds of reproductive health purposes. Mm-hmm. So contraception, pap smears, pregnancy. But even if you separate out all of those visits for gynecological and obstetric care, women still use the healthcare system more than men do. And it's very important to remember that healthcare, or the use of healthcare, is not always an indicator of poor health. In fact, women visit their providers for more well care visits than men do as well, and for some of the reasons that Adam just mentioned.
I think it's really interesting, particularly when you talk about preventative care, because that is probably one of the most critical points that kind of disrupts where things, you get comorbidities and so on, because you get in front of it and it's addressed. And it's so interesting when you think of kind of childhood vaccinations and wellness checks and so on, that it is socialized. But there seems to be a breakdown between your childhood experience and to when you have to take responsibility for your health and wellness. There seems to be a breakdown in obviously I'd love to hear from both your perspectives. What's the messaging? Where is that coming from? That, the preventative care and making sure that you go to the doctor when you have an issue or want to ensure that you're staying, keeping a level of health, that flips.
Well, I think before we talk about gender disparities, it's important to remember that not everybody in our country even has access to health care, or to at least to high quality health care.
Right.
And one of the most important developments of the last 10 years or so, has it been 10 years, maybe a little longer, was the passage of the Affordable Care Act, widely known as Obamacare, which guaranteed for people who did have health insurance that their mammograms would be covered, that their contraceptive methods would be covered at no cost, and all kinds of preventive services that previously some people couldn't afford.
Correct.
So in men's health, I assume that would also include prostate exams.
Right, right, and depression screening. So we look at like values-based care, which is similar. putting some of this onus too on the healthcare system to figure out how do we engage men, women, all people to engage with the healthcare system for preventative screens, for well checks and whatnot. I know as an employee of a healthcare system, I'm grateful that we're required to have annual checkups because that's an example of an extra layer of protection of somebody kind of pushing me to go to my primary care doctor and get screened, get my annual blood work done. But not everybody has that built into to their life.
Yeah, actually, I was going to ask about that related to annual physicals, annual blood work, because I think, Marci, you'd mentioned some people go when they're well as opposed to when they're sick. And I think my sense has been men will go when they're sick, not when they're well, to seek care. What are some, Judy's question, what are some approaches that we can take to help encourage people who do have access to care to actually utilize that care?
Well, I would say like more of this comes, we'll look at like more public health campaigning and marketing, like how do we, and again, something for us to think about like as a health system, how do we put out the education to the community and also approach education in a culturally sensitive way to see how we can meet the unique individual needs of different subgroups of the population that may be particularly at greater risk than other groups. And that really taps into the health disparities piece. So making sure that we're getting the education and the word out there. And just as I wonder, like as we're incentivizing health systems, if there's ways to further incentivize individuals to go and get screened and make sure that they're taking care of their health. But as you said, Rick, it's unfortunate that oftentimes people will wait until they're in dire need of assistance to access care.
Yeah, I'm really glad that you raised the topic of cultural and ethnic identity because here's another place where representation really matters. There is clear evidence that people who see a healthcare provider who looks like them, who shares their identity, whether that's their gender, their sexual orientation, their race or culture or ethnicity, that they have better rapport with their provider. And interestingly, they tend to get better care from those providers. So diversifying the healthcare providers themselves, I think, is something that we need to focus more on. Not that we have a dearth of white male physicians. We have plenty of those.
It's also interesting, even getting in the door, we have historical mistrust. And definitely from the healthcare perspective, from the mental health perspective, how do we even as healthcare providers start to really gain and start to broker some of that mistrust?
Yeah. Well, there I would say, is partnering more with the community. And here's where partnerships with community-based organizations come in handy, or local libraries, where as healthcare professionals, we can get more involved within the community to hear about the perceived needs of the community, also share education. We are part of experts, right? But then the patients themselves, too, the community members are also experts of their own lived experiences. And so we need to get out there and hear what their needs are and how we can best meet their needs. We might have an approach that we think works for all, when in fact that might only work for a subset of the population. And maybe that subset is doing really well. So looking at what are the unique needs of some of the groups that are really struggling, where we're seeing some of these disproportionate rates of illness.
Marci, can you go back? You talked a little about at the top around the disparities in maternal health outcomes. Can you talk more about that?
Sure. So I've spent a large part of my career studying some of the disparities that exist in reproductive health outcomes, particularly in the U.S. that are experienced by African American women. And one of the things that we've been able to show is that, these differences, these disparities are not attributable to biological factors or medical factors. They're due in large part to the experience of being Black, female, and pregnant in the United States. And we've shown that women who are pregnant, women of color, particularly Black women, but also Latinas, who are pregnant face unique forms of discrimination during their pregnancy, and that elevates the stress that they experience. And that takes us back to some of the basic work that we've done over the past 30 to 40 years, showing that stress is a major risk factor. High levels of chronic stress during pregnancy is a major risk factor for adverse birth outcomes. Women who are at high stress are more likely to deliver early, to deliver a low birth weight infant, to deliver an infant with all kinds of vulnerabilities. And I'll say that those health problems don't end at birth. I think a lot of us, if you read the news, are aware of the increase in maternal mortality. Those are deaths among women of color, and a lot of those are actually happening right after birth, in the few weeks after the birth of a child. And that's because some of these problems, the social problems that Adam alluded to earlier, don't disappear after the birth of a child. If anything, they may be exacerbated by the lack of supports that we provide for new families who have a child to care for, the exorbitant cost of childcare, the lack of paid maternal or even paternal leave in the U.S. Having a child in the U.S. is stressful.
So we know a lot. All the things, if we look at the literature, if we look at, our predecessors, a lot of this data, a lot of this evidence, a lot of this testimony, it feels like it's today's testimony. It could be testimony 10, 20, 30 years ago. What changes? How do we absolutely affect change? It has to be systemic and systematic change in a way that is sustainable, and it meets the needs of the patients that particularly the ones that are most vulnerable that we just identified. So how do we partner and collaborate with lawmakers and community partners for some of the hassle factors within social determinants of health? From your opinion, what are some of the things that can really make systemic change?
Right. Well, I would say I think we have been on a really good path, like with the Affordable Care Act and making some really positive changes. And there's great concerns now of where the country's headed, especially when we look at all of the massive cuts to research and science, and how that's going to have an impact on the health that we deliver, new discoveries and whatnot. So that's something really important that we focus on, and how do we work on advocating and working with policy and lawmakers to take a look at what we're putting forward and to really realize the impact that can have on so many people's lived experiences. And then also, like you mentioned, Judi, partnering with the community, right, and getting us out there to really hear the needs and work closely with community groups to spread education and awareness, whether it be preventative screening campaigns and making sure people know that there is support and resources available to meet their needs.
I don't have anything to add to that. I think what our conversation has reminded us of is that change has to occur at many levels. Mm-hmm. At systemic levels, at community levels, families, individuals. We have a lot of interlocking systems that require change, political change, social change, our healthcare system. The question that you asked, Judi, is the $64 million question. And it will take a lot more than $64 million to answer it.
I mean, and even one of the elements of it is also, as you mentioned, Marci, is about representation. Mm-hmm. So people who look like you, have similar cultural backgrounds, identities that are similar to yours. And I think, I look at the work we do at Stony Brook as one of our key values about having people enter, all professions, but the health profession in particular, because these are life and death matters, and we want to make sure there's representation. But I'm challenged with the question of how do you also increase the representation in a more significant way rather than waiting 30, 40, 50 years? That's another big multi-million dollar question.
Did you pick the most difficult questions that you could think of to ask us today? Well, I'll tell you, when I run for president, part of my platform.
Vote for Marci.
She's announcing it
Vote
here.
for Marci.
But I think all of us come from a
Yeah.
mindset of, it's in this work, it's one student at one person at a time.
Yes.
But I think it comes to, how do you accelerate that to again, have a team of health professionals who are reflective of the society you're serving. Right. And we all recognize we're nowhere near where that needs to be.
Yeah, I could share a little, like, from some of my opinions, like, as a healthcare system, and I'm maybe a little biased being a co-chair of our Stony Brook Medicine LGBTQ committee, but I think we have made great strides in addressing health equity for the LGBTQ community here in Suffolk County. And the way in which we've gone about doing that is assembling a really diverse, representative group of leaders throughout our healthcare system and bringing people together to look at what are some of those barriers that are getting in the way of people accessing care. So things like making changes to our electronic medical record, where pronouns are up front and up on the banner bar, so we can address people with respect in the way that they want to be addressed, their chosen names. Also, having education, again, that's tailored to how we can meet the unique needs of the LGBTQ community. We've been talking about health of men and women, and really here I think we ought to be focusing on health for all people, right? Mm-hmm. There are folks that identify as trans and non-binary and face really significant health disparities when it comes to mental health and exorbitant suicide rates as well. And those disparities exist not in a vacuum, but looking at the social political climate when laws and policies are created that then go on to directly impact the individual and limit resources that are present, as well as affect how society views a certain group. And that really manifests itself with lots of negative coping behaviors on the part of those individuals, which then go on to lead to more health problems. Mm-hmm. So it really takes a comprehensive effort to, and we can do that, with applying such a framework to other groups that are significantly impacted and are marginalized groups in particular, to see how we can put resources together to address them and make an impact.
So that brings me to, and you touched on this. No, you didn't touch on it. You actually kind of embedded it in, what does it mean within our education and our professional development? It's like we're creating the next generation of healthcare providers. And so during the times that they're in, they're going through their programs, they're going through, whether they're going through opportunities to observe, all the way through precepts, all the way through, how are we modeling this, and how is it embedded in our curriculum? I wonder, Marci, if you have some insight on that.
I'd love to address that, because I feel very privileged to be a professor at Stony Brook University, a public university that attracts so many students like myself who are the first in their families to go to college. And here's another place where representation really matters. I'm very open about my background. I think it's important for students to know that you don't have to be born with a silver spoon in your mouth in order to pursue a career as a physician, as an attorney, as a professor, as someone, at the higher echelons of their occupation. And there have been numerous times in my career where I've had a student in my class who no one ever seemed to communicate to them that they could reach for the stars. So we have so many diamonds in the rough, if I can use that expression, at a university like ours, and so much opportunity to instill in these students the belief that they can go off and do these things, do the kinds of things that Adam and I have been talking about, whether it's in the occupation related to politics or healthcare or advocacy or so many of the other ways, the approaches to improve our society at large. We are really lucky to have this great pool of talented young people, because at some point they're going to be our gerontologists, our elder attorneys, and our future politicians.
They always thought we did advising, it was for altruistic reasons, but, but we know otherwise.
Yes, absolutely.
You know, as we wrap up our time today, I was wondering if you could each maybe share just your insight or your views on what can we, each of us, do to improve our own health. What are something, whether it's a certain age bracket or certain steps that we should take, because maybe people don't know what to even do. What would be my first step towards a healthier life?
Yeah, I would say, as many of us know, stress can be the silent killer, and we're under exorbitant amounts of stress, chronic stress from hearing things in the news every single day. And so making sure that we're putting into practice adaptive stress management techniques, like developing a daily relaxation and mindfulness practice. There's decades and decades of research on the positive health benefits of exercise. And oftentimes I know myself in this category can struggle with carving out the time to exercise. And at the same time, we know that it's so helpful. And sitting has become the new smoking, and so being able to get exercise into our daily routines and being mindful of our diet and what we're putting into our bodies is also really important. I'll save some for Marci.
Well, any student who's ever taken one of my classes will know I end every class by reminding them to get some physical activity. That's the last thing I always say at the end of class. And I think some of us are trying not to use the word exercise anymore because it sounds like work. So movement, just move your body. Right. And some of the things that Adam mentioned about stress management can be incorporated during your movement. So there's a lot of work right now looking at the benefits of awe, A-W-E. Go out and take a walk. Look at how beautiful the trees are. Listen to the birds. See the budding flowers. It's great stress relief. It's good for your heart. It's good for your soul. That's the number one health behavior to improve longevity. The rest are also good, right? Stopping smoking, limiting your consumption of substances, eating healthy foods, getting enough sleep. That one doesn't always get as much attention, but that's important as well.
What I appreciate what both of you just shared is like really being present and also on your priority, making yourself part of that priority. And I think that is definitely a takeaway that Rick and I and the audience definitely heard from the advice you just shared. So we hope our listeners find these discussions informative and empowering as we navigate these interesting times together. Thank you again for being our guest and your incredible, valuable contributions.
Yeah, Marci and Ab, thank you again so much. We really appreciate your time today. And again, thank you. And Judi, it's been so fun co-podcasting with you.
Exactly.
And we will be back as the fall semester resumes in a couple of months. So we hope you'll join us then. For now, I'm Rick Gatteau.
I'm Judi Brown Clarke. Thank you. See you next time.